Welcome to Cardiovascular Matters. Whether you are looking for answers for yourself or someone you love, we are here to give you the best information available. Each week, the founder of Cardiovascular Institute of the South, Dr. Craig Walker, and medical device sales veteran Terry Roberts discuss the causes, symptoms, treatment, and prevention of health-related issues stemming from cardiovascular disease. Now here's your hosts, Dr. Craig Walker and Terry Roberts.
Hello, everyone, and welcome back to Cardiovascular Matters. You know, we've put together more than a dozen episodes now, and the viewership has been good. I appreciate everybody that's been listening to the channel and making comments. You know, the whole premise of this was to provide information for family members and loved ones that are going through a medical event like this. And you know, I was a rep in working in the labs, medical devices for over 40 years, and I would often walk in and hear family members talking about, you know, I really don't understand what the physician was saying, or I had these questions, or I couldn't hear what was being said. And you know, the premise of this is to provide more information and to kind of slow things down and allow you to really learn about each one of these topics. So thank you very, very much for supporting our channel. Be sure and like and follow our channel, and turn on your if you follow us, you'll get indications when these episodes drop. We try to drop one each week. We're getting better at that, and Dr. Walker has an incredible intensive travel schedule, so we always work around that, and that's fine. But anyway, hope you enjoy the upcoming talks from Dr. Walker and Cardiovascular Matters. Thank you, everyone. Hello, everyone, and welcome back to Cardiovascular Matters. We've been we took a short break. Dr. Walker's been traveling. I think he was in Japan and some other areas around the world, teaching others about peripheral artery disease. While he was away, I was reading an article from a medical economist. Her name's Mary Yost, and Mary estimates that up to 25 million people have peripheral vascular artery disease involving the legs. And today I wanted to start our first discussion about that with Dr. Walker and find out why that's important and how it should be diagnosed.
Sure, Terry. This is something about which I'm very passionate. So peripheral artery disease we define as any blocked arteries or aneurysmal arteries beyond the heart and the arteries going to your brain. But specifically in Mary Yost's article, she was speaking about the arteries that supply the legs with blood. Now, the reason this is so important is, number one, it is highly prevalent. Okay, it is very common, as you've mentioned, at least 25 million Americans. Secondly, it's deadly. And many people do not realize the importance of this. A person with a new diagnosis of peripheral artery disease is as likely to die of a heart attack as a heart attack survivor. And that is because if a person has atherosclerosis involving the arteries to the leg, they're more likely to have atherosclerosis involving the arteries going to the brain or to the heart. Now, we can't easily put our finger on and feel a pulse on heart arteries. In fact, we can't do that at all. But we can easily check for the pulses in people's feet. Mm-hmm. And if those pulses are absent, then that means they clearly have peripheral artery disease. However, one may even be able to find a pulse in a foot, and yet a person can actually even have gangrene from peripheral arterial disease. So just feeling with a finger is not good enough. But if certainly a healthcare practitioner checks a pulse in the foot and it is not there, that deserves further attention. So many patients, in fact, most patients, are either asymptomatic, they have no symptoms at all, or they ascribe their symptoms to other causes. They think it's arthritis, they think they're getting older. And in fact, in a big trial looking at this, called the Partners trial, they found that most of these people at first did not recognize that they had the typical symptoms that we see are associated with peripheral arterial disease. Yet it's very interesting. Once asked questions about the symptoms that occur with peripheral arterial disease, many did have them. They just attributed to either getting old, arthritis, as I've said, or things such as that.
Right.
Now, in my opinion, that is wasting a great opportunity to save a life. If one is not terribly symptomatic from the peripheral arterial disease, we don't need to fix the leg artery at that point. But what we do need to do is we need to modify their risks. We have to have that patient quit smoking. We have to control their cholesterol. We have to control their diabetes and control it with certain medicines that have been shown to lessen cardiovascular risk. We have to lower cholesterol to very low levels. We have to encourage a walking program. And if they have no big risk of bleeding, perhaps we should place those patients on things such as aspirin. By doing that, we can save lives. We can save many lives. And often we can help to diminish the likelihood of progression of this disease. So, whereas we make a lot of noise about our ability to go in and open blocked leg arteries, and certainly in people whose legs hurt every time they walk, or in people at risk of losing their legs, we have just had major breakthrough after major breakthrough, allowing us to save most legs. And certainly intervention and surgery there can be life and limb saving. But where I think we're falling apart most is that we're not using this warning to take a more holistic approach with the patient and say, okay, yes, you do have leg blockages, but that may just be part of the problem. Let's make sure we check things. Now, as you might imagine, many people who have leg blockages can't walk very far because the muscles don't get enough blood supply and the legs cramp, particularly the calf muscle cramps, or sometimes it's the buttocks that cramps. And that's the typical symptoms that people ascribe to peripheral arterial disease. And of course, at the far end of the spectrum are non-healing wounds, ulcers, and worse yet, gangrene. Now, sometimes this is not a slow progression, but usually there is a slow progression from no symptoms to early symptoms to worse symptoms on to most severe symptoms. And like anything in medicine, the sooner we can get to this and the sooner we can start preventive care, the better will be the outcomes. I think this is absolutely paramount. In our Medicare catchment region, we have shown dramatic decreases in both cardiovascular mortality and in amputation. And I think a lot of that is related to peripheral arterial disease and starting these patients on preventive measures. Once I can show someone that they have a blocked artery in the leg, and we can do that by simply feeling a pulse or by doing an ultrasound or doing an angiogram. Once I can show them that, typically most patients get a lot more serious about taking medicines. As long as people can think, boy, everything's fine with me, nothing's going to hurt me, it's sometimes very difficult to start these preventive measures. But once we can show someone this, it matters. Now, I like to divide the symptoms of peripheral arterial disease when they are bothering people into the following. One is claudication. Claudication is pain in the muscles when we walk, and that's due to inadequate blood supply. And there's such a thing as walk-through claudication. Often people walk, the leg hurts, they stop for just a second, and then they can walk much further. That does not rule out that that's peripheral arterial disease. In fact, that's most typical of peripheral arterial disease. Now, we can make that diagnosis really simply by measuring pressure in the arms and pressure in the feet. They should be the same. If they're not, if the leg pressure is lower than the pressure in the arms, there's peripheral arterial disease. Now, that's the easiest method, but we have more sophisticated measures that let us tell which artery, how bad is it blocked, etc. But, that's the first symptom. The other thing that we see are signs. Often there's loss of hair on the lower extremities. Hair is a tissue. It needs blood supply, just like anything else. Typically, leg swelling is not a sign of peripheral arterial disease. That's more a sign of venous disease. Yeah. And so that's where we start. Then, as it gets worse, it can develop pain at rest. That we call Rutherford 4 classification. Now, if someone can't walk really to their mailbox and they're on all the appropriate medicines and care and they're pretty miserable with this, that's Rutherford 3. And Rutherford 2 is when you can walk but your legs hurt. There's a lot less need to jump in Rutherford 2. Rutherford 3, certainly sometimes we would prefer intervening, particularly if someone wants to maintain a very active lifestyle. But once we get to Rutherford 4, which is pain at rest, where you're having to hang the legs down just to get enough blood flow to keep them alive and to help with the pain, or Rutherford 5, where you have a wound or an ulcer that's not healing, or worse yet, Rutherford 6, where you have gangrene. That is called critical limb ischemia. Rest pain, non-healing wounds or ulcers, or gangrene. And that constitutes a huge part of my practice. I've treated people from all over the world with critical limb ischemia. Now, unlike just claudication or pain when you walk, once you have critical limb ischemia, it's typically required that we do some form of treatment to restore blood flow to the legs. And that's because patients presenting with critical limb ischemia will experience a high rate of amputation if that can't be treated. Right. So let's go back, though, and we'll speak about critical limb ischemia. Then we'll speak about the most severe presentation called acute limb ischemia.
Right.
But with peripheral arterial disease, when I see this, it is, I think, to me, what a red flag waving in front of a bull must be to that bull. Because I'm thinking this is a problem. I'm thinking this is something we should evaluate, and not just evaluate the legs. You know, historically, when people thought someone had peripheral arterial disease, they treated it as an isolated problem. I've said, and I've said this at conferences around the world, sick legs are almost never attached to healthy people. And I think that's a very, very easy thing to understand. Now, the risk factors for blockages in the leg arteries are pretty much the same as those for heart blockages or carotid blockages. However, certain risk factors are more important in peripheral arterial disease. What are they? Well, number one is advanced age. And although I've had patients with severe peripheral arterial disease who are sub 20 years old, typically severe juvenile diabetics, most of the time, this is a disease of senescence, of people getting older. So if we look at people who are 70, they're more likely to have the disease than those who are 60. And if we see those that are 80, they're more likely to have it than those who are 70. So it is a disease of senescence, big risk factor. Other big risk factors, smoking. And diabetes mellitus. And when we speak about critical limb ischemia, same things. These are the same major risk factors. And we know certain things make these problems yet more dangerous. If there is associated kidney failure and one is on dialysis, that portends a much worse prognosis. Obviously, if there are blockages in multiple vascular beds, like those going to the heart, those going to the brain, those going to the gut, we call that polyvascular disease. And once again, that is associated with worse prognosis. Now, the medical therapy of this has been amazingly impressive as to what we can do. First off, we would want to put these patients, if they're not at risk of bleeding, on low-dose aspirin, and possibly even an antiplatelet agent such as a drug like Plavix or clopidogrel.
Okay.
Now, we then have to control their blood pressure. Smoking cessation is of utmost importance, and we can no longer just tell a patient, hey, quit smoking, it's just something you do. Smoking cessation is necessary, and smoking addiction is a real disease.
Right.
People are physically addicted to the nicotine in cigarette smoking. Same is true for obesity. Obesity is a disease, and many people cannot break that disease, and we've talked about that in the past. Now we have remarkable medicines that allow us to treat patients who have obesity, and I've had weight loss surgeons tell me they think these drugs will end the need for bariatric surgery. I've had many say that. That's how incredibly impressive these drugs are, and they don't only make people lose weight, they actually lessen your risk of dying of heart attack or stroke or other cardiovascular problems. They tend to improve cholesterol. Now, other things we do, we would want to lower cholesterol. We'd want to start a walking program. The more that we make a person walk who has peripheral arterial disease, the more the body tries to make its own natural bypasses around blocked arteries. This is very important.
Collaterals, they're called collaterals?
Yes, these are called collateral vessels. And so it is a very effective treatment of peripheral arterial disease to start a walking program. And what I advise a patient to do is to walk until they hurt, take a short break, and keep walking, and to keep do this. Often that alone will alleviate those symptoms. And so in the case initially of just finding a diminished pulse or a patient who has claudication, the treatment is really more preventive. We do not have to jump in on that patient right away. And then finally, there's a medicine that's been shown to improve blood flow to the legs. It is called cilostazol. Now, this makes red blood cells more malleable, and therefore you can improve blood supply to the legs. But I think those are very important. But you know what's very important as well? Screen those people to make sure they don't have coronary disease or carotid disease. Check their carotids with an ultrasound. At least do something called a calcium score of the heart. If that person has advanced calcium in the coronaries, that portends a much greater risk that that patient could go on to have a heart attack. These are simple tests, but they're simply, to me, dotting the I's and crossing the T's. And in medicine, you know, we have very, very heroic things that we can do, but still, it's like anything else in life. Dotting I's, crossing T's is where we have to start. So I think every patient should insist that their healthcare practitioner checks the pulses in their feet, checks the pulses in their arms. So many diagnoses can be made from simply doing that. And that really does rule in or out the vast majority of people with peripheral arterial disease. That's where we start. If we can't get a clear answer just from that, simply measuring pressure in the arms and pressures in the feet. Really simple things, very easily done, no risk. And as a screen, this is far more cost effective than in terms of saving lives than screening for breast cancer, screening for cervical cancer. And certainly those are very important. I'm not trying to suggest we shouldn't do that. What I'm suggesting is that we absolutely should be screening for peripheral arterial disease. And certainly anyone over the age of 50 who's had diabetes or ever smoked should have that checked.
Right.
And anyone over the age of 70 just by reaching that age. What has been found in the Partners trial is that almost 30% of people I've just mentioned, people with diabetes or who smoke, greater than 55 years of age, or anyone over 70, 30% of those, roughly 29% to be exact, have peripheral arterial disease. We can't ignore this.
Right.
We have to deal with this better. And with that, I think I'd like to end this particular segment. And we will then discuss what are some of the treatments that we have. And then we can go on in the future speaking about critical limb ischemia and acute limb ischemia.
That's awesome. You know, that's a great presentation. And, you know, what it tells me, I mean, I've been around your practice for 30 years and, you know, in the lab, participating in cases. And so often patients show up at your office and they're already, they've not been diagnosed. They've told themselves it was old age or this or that. And then they find themselves in scenarios where they do need an intervention. They need the vessel opened. But what you're describing is something that, number one, will educate our listeners. But, you know, again, physicians, healthcare providers, this is easily diagnosed. And if you educate the patients from very simple things they can do to not cure this, but certainly prolong a healthy existence, you know. So we'll end it right there, and then we'll be back next week, and we're going to take a deeper dive on critical limb ischemia, the next phase.
Thanks for listening, and please subscribe, like, and share this podcast with your friends and family. Join us next week for new topics and answers with Dr. Craig Walker and Terry Roberts on Cardiovascular Matters.